Good afternoon, everyone, and welcome to the TxRx Medications for Substance Use Disorders ECHO, brought to you by Bevel, Texas. Please note that we are recording these sessions for later distribution. Please note that anything listed in the chat will not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat, which can be accessed by clicking on the speech bubble on the navigation bar at the bottom of your window. If you are one of our Bevel Texas providers, please make sure that you identify yourselves during the session. If you are joining via phone, please email your phone number and name to beveltx@ithaska.edu. Some housekeeping: please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is at the bottom left of your Zoom controls. If you're on the phone, just press *6. We encourage everyone to speak at these sessions, especially during the discussion portion. We want to hear from as many of you as possible, so please keep your comments brief to allow others a chance to speak up. If you can also use the chat feature to share your comments and questions. Please note that no protected health information is allowed either in the chat or in the discussion, and that means names, emails, addresses, or any information that can easily identify an individual. If you would like to view closed captioning for this session, please navigate at the bottom of your Zoom window and select the Show Captions option. You may need to click on More to access this. If you are having trouble accessing captions, please message ECHO IT. Towards the end of the session, the Bevel Texas team will send out a link to an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on crafting strategies for the diagnosis and management of psychostimulant-induced psychosis and will be presented by Dr. Daryl Shorter. Following that, we will discuss a case presented by Dr. Jacob Mum. We will start with some introductions, followed by didactics, Bevel program announcements, case presentation, and open discussion. Thank you all again for joining today's ECHO. We look forward to learning alongside you and encourage you all to share your experiences, questions, and insights during this conversation. And with that, we will do some introductions. Dr. Waklu.
Good afternoon, Siddharth Waklu. I'm an addiction psychiatrist at UT Southwestern with the rank of professor. I'm the director of the Clinical Addiction Psychiatry Services at UT Southwestern and the Addiction Psychiatry Fellowship Program. And I welcome everyone. Look forward to hearing Dr. Shorter, who's a close friend and colleague.
Thank you so much. Dr. Walker.
Good afternoon, Crystal Walker, doctorally trained PA, and I'm the director of the Substance Use Disorder Services Medical Services with MHMR of Tarrant County in Fort Worth, Texas.
Thank you so much. Dr. King.
Hello, everybody. I'm Van King. I'm a addiction psychiatrist at UT San Antonio. I'm a professor here, and I'm the medical director of Be Well, Texas.
Thank you so much for joining us. Dr. Shorter.
Good afternoon, everyone. I'm Daryl Shorter. I'm the medical director of addiction services here at the Menninger Clinic in Houston, Texas, and I'm an associate professor of psychiatry in the Baylor Department of Psychiatry, Baylor College of Medicine Department of Psychiatry. So really happy to be here today. Thanks so much for having me and to see so many familiar faces and friends.
Thank you so much for joining us today. Dr. Mum.
Hello, I'm Dr. Mum. I'm the medical director for Olive Branch Recovery, and happy to be here.
Thank you so much. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal. I'm the TxRx ECHO coordinator. Thank you for joining us today.
Thank you. And with that, we will get started with our didactics. Dr. Shorter, you can take it away whenever you're ready.
All right, thanks so much. Really excited to speak with you today about a topic that I think can sometimes be a little bit of a confusion or a conundrum for us. I have about 20 to 25 minutes, and more material than I can probably fit reasonably in that amount of time. And so I want to let everyone know that, of course, my slides can be made available to you. With that, I'll go ahead and get started. I have no financial disclosures to report today. So I want to spend a little bit of time just talking about the prevalence, risk factors, and some of the clinical manifestations of stimulant-induced psychosis. We'll spend a little bit of time really comparing and contrasting stimulant-induced psychosis with other types of psychotic disorders, particularly schizophrenia, and also spend kind of our final time together discussing a treatment approach for the management of stimulant-induced psychosis. So I would like to begin with a case. This is a case of an individual that I was working with in the last month. Kind of fresh and hot off the presses. This was a 25-year-old Caucasian male. He presented to our clinic here. He'd endorsed a 2-week history of manic symptoms. His mood was fluctuant, really alternating between high highs and low lows. So he did describe euphoria and elevated mood, as well as crashes and depression. Decreased sleep need and racing thoughts occurred within the context of those manic symptoms. And these seem to take place primarily during stimulant intoxication. During the crashes, he would report severe depressive symptoms, including depressed mood, feelings of guilt, and worthlessness, particularly related to his substance use. He had low energy, exhaustion, as well as passive suicidal ideation. Interestingly, he also reported a belief that he and his families were the victims of an elaborate cyber attack via mobile device, and this belief that perpetrators were trying to extort him and other members of his family. He also reported that he was hearing whispers about others making comments and telling him how he was actually in danger. It's important to note that outside of these perceptual experiences and these beliefs, his mental status exam when I first saw him was otherwise unremarkable. He was pretty motivated for treatment because his wife had just kicked him out and reported and told him that she was planning to divorce him. I'll give you a sense about what his substance use looked like when we first began working with him. So he was a smoker. He began smoking as a teen and continued to smoke even when I first evaluated him. He began drinking alcohol around age 15, and cannabis use came shortly thereafter. Opioid use entered the picture for him around age 16. He started off using prescription pain relievers that were made available to him either through leftover prescriptions in the home as well as through friends at school. Benzodiazepines came into the picture much later, around age 18. And it's important to note that he had had a previous diagnosis of ADHD and had been prescribed dextroamphetamine. Now, around the time of age 16, he was no longer prescribed that, and so his use of dextroamphetamine was actually fairly intermittent because the prescription had been discontinued. Cocaine came into the picture for him around age 18, and then methamphetamine shortly thereafter. At age 20, he had a pretty significant intervention that took place within the context of the family, and he was able to establish abstinence and sobriety. Around age 23, he resumed use of alcohol and cannabis. This was after he'd gotten married, started school, was working. Things in his life had gotten really quite stable during that period of prolonged sobriety. Shortly after he resumed alcohol and cannabis use, cocaine came back into the picture. Opioids then shortly entered in after that. And by the time he was on opioids again, methamphetamine had really come back into play for him as well. So at the time of his presentation, for about a month or two, he basically went on an extended, prolonged run using heroin and fentanyl, as well as methamphetamine. And as you can see, alcohol by that point and cocaine were really not even that much of an issue for him because he was really so focused on the opioid and the methamphetamine use. It's important to note that during that period of time between age 20 and age 23, when things were going well for him, he was not psychotic. He was not on any medications for depression or anxiety. He had a history of migraine headaches and was prescribed Depakote specifically for migraine headaches, but really did not have any history of mania, manic symptoms, or a diagnosis of bipolar disorder. So hearing a case like this, probably a lot of things may begin to come to mind for you. And so one of the first questions that we might ask, he presents to your clinic, which of the following actions might be the most appropriate next step? And you might want to do all of these things at the same time, but like if you really had to narrow it down, I'm kind of asking you to just in your mind think about like what you might like to do next. So performing a medical evaluation seems like a completely appropriate next step in terms of getting labs because of the types of behaviors he was engaged in while he was under the influence, STI screening, maybe a head CT, lumbar puncture, EEG. What might make you think of getting some of those tests in the context of someone presenting with this type of psychosis? We recognize that he also is going to be experiencing a polydrug withdrawal from both the opioids as well and fentanyl, including fentanyl as well as methamphetamine. So maybe the first thing we want to do is manage the drug withdrawal. Initiating pharmacotherapy for this sort of unspecified psychosis that he's got, where he's reporting delusional beliefs, paranoia, as well as auditory hallucinations. Or is it more important to initiate treatment for depression because he's reporting passive suicidal ideation? Or maybe you do none of those things and you just try to provide MI to promote the establishment of abstinence, and maybe you hold off on prescribing a medication. I'll let you kind of wrestle with that. So other considerations that I kind of made when I was first evaluating him and things that I think come into play when we're thinking long-term about how to manage folks is there was this historical diagnosis and treatment with of ADHD. So he was someone that maybe had been at greater risk for going on to initiate substance use and develop a substance use disorder as a result of ADHD. Perhaps that was either untreated or undertreated. And then how does that play into what you do now? Should you prescribe a psychostimulant for this guy for ADHD? And what would untreated ADHD look like for him now in the context of trying to establish abstinence, reducing impulsivity, and helping him to think through recovery management skills? What about the specifics related to substances? What's the contribution of cannabis here? What about the contribution of alcohol, opioids, and benzodiazepines? Are those playing a role in the development or sort of the manifestation of psychosis here? And then psychostimulants, of course, as a result of him using psychostimulants and then also experiencing a lot of sleep deprivation, how does that then play into the development and manifestation of psychosis for him? And then most importantly, what does that period of abstinence really tell us about the presence of what we might refer to as a primary psychotic disorder versus something that is perhaps substance-induced or stimulant-induced? So a little bit about when to perform certain tests, to go back to our earlier question about the workup. So these come directly from the practice guidelines, and I've included the website here. This is for how to treat stimulant-induced use disorders. And I really strongly recommend that you download them and review them and refer to them, particularly in tough cases like this. So indications to perform a head CT, if this was someone that had presented with an altered mental status, neurologic symptoms, TBI, if he had been found down or unconscious, or he'd experienced an anoxic injury, then those might be indications to perform a head CT. In his history, he did not really describe any of those things to us. However, he had a head CT when he was admitted to an inpatient psychiatric facility prior to coming to see me. So no need at this point to repeat a head CT. We're just kind of going to use that presentation as clinical data. Indications to perform a lumbar puncture or blood test for encephalitis would be unexplained fever or meningeal symptoms. And again, this was not a situation where he presented with any of those things. So LP probably not warranted at this point. When it comes to indications for an EEG, seizure, neurological symptoms, or persistent encephalopathy, all things that were not present in this case, but those would be things that might lead you toward getting an EEG. And then these other additional causes that I list here. So you might do some additional lab tests for thyroid function. You might do your neurologic exam to make sure that there isn't any sign of like brain tumor, or you would maybe order a CBC to try to test for infection or elevated white count. But again, in these situations, not necessarily seeing an indication for that among in this particular case. So a quick word about stimulant use by the numbers, and this is all data that comes from SAMHSA's most recent National Survey on Drug Use and Health. When we look, we've got about 70 million people in our country in 2022 had past year use of an illicit substance, cocaine being the most prevalently or most widely or commonly used psychostimulant, followed by prescription stimulant misuse, and then following that, methamphetamine. Now, what is interesting to note is that about almost 20% of people that use one type of stimulant will use another type of stimulant. And so part of our approach with patients when they report to us perhaps that they use something like methamphetamine or they use something like cocaine is to really go down the list and ask them if there is a use of another type of psychostimulant, because we can maybe estimate that about 1 in 5 people will have a combined form of stimulant use. When it comes to prescription stimulant use, we've got almost about 4% of folks age range 18 to 25 that are having past year prescription stimulant use. When we look at cocaine, again, about almost 4% here. And then finally, about 1%, a little over 1%. And you can see that among your older folks, maybe 26 or older, you might be a little bit more likely in that group to see methamphetamine use in comparison to your 18 to 25-year-olds who may be more likely to have prescription stimulant use or cocaine use. Okay, back to our case. So the doc initiates buprenorphine for opioid withdrawal and rules out acute medical concerns. Now, which of the following medications would be most appropriate? Now, one of the approaches here that I think, just to back up to the actual stem of this question, the opioid withdrawal can be so uncomfortable for this individual that it actually becomes a barrier to receiving other types of treatment. So even though this is a stimulant case per se, if you don't stabilize that opioid use disorder, then it can be an incredible risk for going back to substance use and continuing opioid use in particular. Okay. So once the OUD is stabilized and you've ruled out any acute medical concerns, what medication might you try? And we've got 5 antipsychotics listed here: aripiprazole or Abilify, haloperidol or Haldol, olanzapine, zyprexa-clozapine or Clozaril, or chlorpromazine, also known as Thorazine. So when we look at some of the studies that have really compared what is most effective to treat psychostimulant-induced psychosis, olanzapine and quetiapine have been found to be superior to risperidone. So already we're beginning to kind of create a hierarchy of medications that might be more appropriate to use in a case like this. So olanzapine comes up to mind and quetiapine comes up to mind as well. Olanzapine and haloperidol or Haldol appear to have equivalent efficacy, but there are fewer side effects and perhaps faster symptom resolution with olanzapine. Aripiprazole is inferior to all of these other medications, and so significantly lower on our list if we were to decide to use it at all. Clozaril and chlorpromazine can maybe increase this risk of seizure, and so again, maybe lower on our list of medications to try. But then there's a question about for how long do we treat someone? Is this going to be treating someone indefinitely, or do we employ a taper and try to get the person's symptoms stabilized and then step them down off of that medication over a period of time? So when it comes to teasing apart the diagnosis, I want to talk a little bit, just compare DSM. So with schizophrenia, you've got 2 or more of the following symptoms that are required. This is someone who would have delusions. So our patient came in with a paranoid delusion and a belief that his phone had been hacked and that he was being extorted. Hallucinations. He also reported auditory hallucinations, hearing whispers and feeling that people were talking about him. Disorganized speech he was not particularly disorganized. And I think that that's an important component of how it is that we begin to tease out what's what when we're comparing schizophrenia with stimulant-induced psychosis. No, there was no gross disorganization or catatonia. And from a negativistic standpoint, it wasn't particularly negativistic, although there was some blunted affect and maybe some lower motivation, although that could certainly be attributable to either substance withdrawal or the presence of an underlying depressive illness. So in the impairment that you expect to see with you would expect to see functional impairment with somebody who's diagnosed with schizophrenia. The time course is that the person would have to have been experiencing these symptoms for more days than not over a 6-month period, and you would want to rule out all of these other causes, including substances. When it comes to our more psychostimulant or substance-induced type of psychosis, you could have either the presence of one or both delusions and hallucinations, and this gentleman presented with both. There was historical evidence of these symptoms developing within the context of intoxication and or withdrawal. That's why that period of sobriety and that period of really understanding that there were no symptoms of psychosis, no symptoms of mania in the context of that episode of that prolonged episode, really of 3 years of abstinence can be so helpful with teasing this out. We are able to establish that etiological relationship of substance use to psychosis. The patient was not delirious and was not experiencing any symptoms of a medical condition, and so we wouldn't necessarily think that delirium was present. And then finally, he was certainly in distress clinically. When it comes to the pathogenesis of stimulant-induced psychosis, I think, of course, we can obviously think about stimulants which can increase dopaminergic activity as well as cathinones, but there can be a contribution from cannabinoid CB1 receptor agonists. There's obviously a lot of conversation about the contribution of cannabis use to the manifestation of psychosis in people, and perhaps the increased risk and manifestation of schizophrenia in people that begin cannabis use, particularly as adolescents. There's 5-HT2A agonists, things like hallucinogens, so LSD, PCP, phenylethylamines, like 2C. There's NMDA antagonists like PCP, ketamine, and also our K opioid receptor, I'm seeing this all over the place as well. Not as much salvia anymore, but lots of kratom. Kratom seems to be widely available in many of the head shops that are here around town in Houston. So the questions that we could begin to kind of ask ourselves about the course of this illness really begin like, one, at baseline, is psychosis present? And again, with this case, we got a really great example of how in the absence of substance use, psychosis was not present. So then it becomes like, okay, well, he's presenting, is this going to be just a result of the acute intoxication and withdrawal that's causing transient psychotic symptoms, which need to be treated, or has chronic use of substances for a long period of time now resulted in the manifestation or the development of a syndrome that resembles a primary psychosis, even in the context of abstinence? And at this point, it was a little too early to say one way or the other, but the psychosis was present and it required some treatment. So we can think a little bit about some of the differences between schizophrenia, cocaine-induced psychotic disorder or psychotic symptoms, as well as methamphetamine-induced psychosis. And one of the things that I think can really be helpful is the presence of negative symptoms. If someone is experiencing negative symptoms, that almost always kind of lets us know that you may be skewing more toward a primary psychotic disorder or schizophrenia in comparison to a substance-induced or stimulant-induced psychosis. The other piece of it is thought disorder. You might expect that people who are experiencing stimulant-induced psychotic symptoms, that they might be a little bit more disorganized, but that isn't necessarily what you always see, particularly in the case of cocaine, where that's not even necessarily talked about as much at all. You might see some of that conceptual disorganization on the side of methamphetamine use. And so really trying to get a sense of that history, how long has that been present, perhaps speaking to collateral informants to get a better sense about whether or not thought disorder or thought disorganization has been present for a longer period of time. That also could be one of the symptoms that you continue to track over the course of your treatment. Does the disorganization persist, or does it seem to resolve with your treatment and or with abstinence? When we think about cocaine-induced psychosis in particular in comparison to primary psychotic disorder, and I think that this in some ways can also be kind of true for meth-induced psychosis as well. We're really talking about other types of risk factors like family history. So getting a good family history is one way of beginning your assessment of whether or not psychosis is present for this individual as a result of substance versus a primary psychotic disorder like schizophrenia. How exactly and when exactly did these symptoms come up? So asking questions about schizophrenia prodrome, asking about change in personality, development of depression or mood symptoms while in high school or shortly after high school. When did these symptoms kind of begin? Now, for this particular patient in the case, it was challenging because the substance use for him had begun so early. And so getting out and kind of teasing the presence of depression, the presence of anxiety in someone who's 16 or 17 years old, but has a poly-substance, poly-drug use can oftentimes be challenging. And so I want to acknowledge that here. If someone has substance use prior to their presentation, that of course is required for the diagnosis. But in the case of a schizophrenia or other type of psychotic disorder, there may be no substance use, although that might also be present, as they can certainly coexist. While on the side of cocaine-induced hallucinations, you might be more likely to see visual hallucinations. You may be more likely to see auditory hallucinations in primary psychotic disorder. The types of delusions, since we're really kind of teasing out the nature of those delusions, you may be more likely to see persecutory delusions in the context of stimulant use or stimulant-induced psychosis versus delusions about possession, special messages from God, often very bizarre types of delusions in the context of a primary psychotic disorder. Again, we've talked about negative symptoms and how that can be a helpful way of kind of teasing things out. And you might be less likely to see things like a history of trauma, history of legal problems, antisocial personality disorder in the context of schizophrenia, and also insight. That's a really important one. So when I was speaking to this patient about whether or not his phone was being tapped and he was being extorted, he was able to almost reality test in the middle of that conversation to say, well, this could be happening, but I'm not sure. There was a part of him that had some of his insight intact, and we might not necessarily expect to see that present in schizophrenia. Okay, a quick word about cannabis. Initiation of cannabis use, as I mentioned, particularly during adolescence, is a risk factor for the occurrence and severity of cocaine-induced psychosis in cocaine-dependent individuals. And so there is potentially that synergy that kind of they kind of play off of each other and may ultimately cannabis on its own with somebody who is cocaine dependent might actually increase their risk for developing a psychotic disorder. So what's important, I think, for part of our psychoeducation with patients is to let them know, oftentimes people think, well, the cannabis isn't necessarily a problem, or it's less of a problem than the cocaine is. Okay, and that in some ways from a functioning standpoint, that may be true or that may feel true, but at the same time, certainly the co-use or co-administration of cocaine and cannabis can be associated with perhaps an increase in the development of psychotic illness. Some risk factors to kind of be aware of when it comes to cocaine-induced psychosis, having a younger age of onset, longer duration and severity of cocaine use, and certainly if they've had a history of psychosis, as well as some other psychiatric conditions like ADHD, which our patient had, antisocial personality disorder or borderline personality disorder also can be associated with cocaine-induced psychosis, male gender, lower BMI, and then some genetic polymorphisms. Now, when it comes to methamphetamine-induced psychosis, more frequent methamphetamine use, the quantity of meth used, and also greater severity of meth addiction can be sort of associated with the development of psychosis. And this is distinct from cocaine, right, where we're talking perhaps about earlier onset. Really, we're talking here about like how frequently they use, and then also the nature of the meth that's being used, crystal meth versus other forms. And there may be something specific to methamphetamine in terms of its chemical structure, as well as the amount that people use that really kind of predispose them to going on to develop meth psychosis. So in our final moments together, and I'm running up on time, I just want to talk a little bit about a treatment approach, and then I'll stop and can answer questions during a later portion of the conversation. So one of the things, and I think that this may be one of the hardest aspects of our jobs, and when we do this work in managing and helping people to think through treatment of co-occurring disorders, is that sometimes my goals for the patient are different from the goals that the patient may have for him, her, or themselves. And so I try to approach with this idea, let's just focus on reducing harms. And what does harm reduction look like in the context of this particular case? We've got serologic testing, HIV PEP and PrEP, vaccination, and screening for chronic medical conditions. Talking to the patient about their substance use goals and really aligning with them and saying like, okay, well, these are the things that I want to work on with you. And then also providing pharmacotherapy for those. From a mental health standpoint, we've spent the entire time here today talking about mental health screening, but really assessing for safety, particularly suicidality, homicidality, and getting people in to see the appropriate mental health clinician. And then also if there are social or structural determinants of mental health that might be contributing to the presentation of this individual, making sure that they have the appropriate supports. And with that, I'll go ahead and stop sharing and say thanks for your attention today.
Thank you so much, Dr. Shorter, for this wonderful presentation. I will open up the floor for any questions or comments from our learning community here.
I have a question. So I was wondering if you had noticed, is there any, like, you know how chronic alcohol use can lead to long-term encephalopathies? Can chronic amphetamine use lead to any kinds of long-term encephalopathies, even with cessation of the drug?
Yeah, that's a really excellent question, Dr. Mumm, and one that I think we see clinically happening for folks. Well, you know, there are patients that may come in and they report a 20, 30, 40-year history of using psychostimulants, and there's a kind of a bizarreness to perhaps their presentation. It's not, it doesn't like meet our clean DSM diagnostic criteria all the time. Sometimes there just is a way of thinking about or seeing or viewing the world that seems slightly askew from what you might expect from someone who does not have a primary psychotic disorder or schizophrenia. The other thing that people can sometimes have these perceptual experiences, kind of hear voices, hold some bizarre beliefs, and it's just, I think it is entirely possible that if you have these micropsychotic episodes over and over and over again, some of those brain pathways just dig in and persist, despite the fact that someone has maybe been able to establish abstinence, and even in some cases where they're prescribed antipsychotic medications.
Dr. Shorter, excellent presentation. That was lovely. Now, quickly, do you see the chronicity of meth-induced psychosis much more as compared to chronicity of cocaine-induced psychosis?
Yeah, that's a really great question. What I will say is that your chronic cocaine, this is all anecdotal at this point. Okay, so your chronic cocaine users, these are your folks, like I was just mentioning, Dr. Mumm, like these are folks that have been using for decades, right? And so as a result of this kind of decades-long use, they have developed this psychotic way of thinking and sort of seeing the world. Our meth users, they seem to develop psychosis earlier. Like they don't have to have had, they don't always have to have had decades of use in order for this psychosis to really have set in for them. You know, I've got another young person in my outpatient clinic right now who became fully psychotic, and this was after 1 year of methamphetamine use. So there's something I think different about like the dopaminergic activity that takes place, the long-acting nature of methamphetamine, perhaps the way that people use it in comparison to cocaine, that seems to make it so that like with less use, people become psychotic with methamphetamine in comparison to cocaine. And then there's also those people who, God love them, they've been using cocaine for 30 years and they are not psychotic. It's just terribly interesting.
And you're less likely to see that with meth, that people with any long use tend to have some level of psychosis, more likely than cocaine.
Yeah, I mean, our longer term meth users typically seem to have more severe psychosis, and also sometimes greater psychosocial consequences, negative consequences from their use. Not to suggest that people with cocaine don't experience those as well, but like just the level of kind of impairment seems to be a bit greater and come on faster with meth in comparison to cocaine. I remember my first, like when I started my job as an attending, I was at the VA before I came over to Menninger. And people would come in and they would say, oh yeah, I've been using cocaine for 25 years. And they're just like sitting there talking to me like I'm talking to you all right now. I was like, huh, this is interesting because it sort of flies in the face of what it is that we think about for someone who is a chronic stimulant or chronic cocaine user. Like, why, and they, and they would use a few times per month. They weren't really necessarily seeking abstinence. Sometimes they were, sometimes they weren't. They may have been prescribed an antidepressant. They may have been prescribed an antipsychotic, but they just were like sort of doing the deal, doing life while they were also chronic cocaine users. Okay, for our meth users, that does not seem to be the case. I mean, the bottom just falls out for them so much. And the severity of the psychosis in comparison just seems so much greater when we think about it in comparison to cocaine. Oh, I think
Rachel?
Thank you. Excellent presentation. Thank you. I'm in long-term recovery myself, and I was a cocaine user. I have 9 years in long-term recovery right now. I do have a theory. I am not a doctor. I am not a social worker. I'm not a psychologist. This is just a theory on what you're commenting on, because I've noticed that too with the women that come into my program. The difference between cocaine use and methamphetamine, because I wasn't a methamphetamine user. Could it be the chemicals in the drug? Because I've noticed the women who have had the long-term meth use 10, 20, like you said, 30 years, teeth ruined. And if methamphetamines can eat your teeth up like that, what is it doing to your brain? And not that cocaine is not, in that category, because it does, but I never had any psychotic episodes, That is just that's my personal theory. So love to hear what your response would be on that.
Yeah, well, Rachel, first of all, congratulations on long-term sobriety. That's awesome. Thank you so much for being and for sharing your perspective and your history. Like stories like yours are exactly what we need to hear in this field. So thank you for sharing. I actually think you're right. There have been some studies that have really talked about and looked at the way that methamphetamine is manufactured in comparison to cocaine. Now, we're amongst friends here. We all know that these substances come to the street and they are not pure, right? Like I think we can all sort of acknowledge that. But some of the impurities that are a part of the manufacture process, that like sort of shake and bake process that can sometimes take place with methamphetamine, do seem to be associated with like higher likelihood and manifestation of psychotic illness. And so, Rachel, I think you are spot on with the sort of creation of the manufacture of these chemicals and how they are like fundamentally different in the manufacture process, and how that ultimately does impact people and make it sort of more likely for people who are meth users to experience psychosis. Yeah.
Dr.
One
Shorter.
thing I'd like to add on to what Rachel said, I'm also in long-term recovery. I've been sober from cocaine for about 20 years now. And one of the things I saw when I go back to my using days, those of us that were doing cocaine, we sort of had an ebb and flow. There was a time in which we'd come down, eat, sleep, drink water, do things like that. With those times where I experimented with methamphetamine, I just couldn't hang with them because they would do it and they're up 5 days. So you're talking about sleep deprivation,
Right.
dehydration, no nutrients in their body. And so I would imagine that psychosis is going to be amped up because I'm also suffering from the dehydration, which makes people crazy, right? That can bring you in psychosis. So I noticed just the pattern of use, not just the trash. I tell people you opened your kitchen cabinet and made some drugs. At least mine came from a plant. Right. So I think between the mixture of all the mess that makes methamphetamine and then the extent in which you can remain awake, but not meeting just your basic needs, unlike cocaine. Eventually, I did so much cocaine, I'd go to sleep. I could literally do so much and eat. Right. Never that on methamphetamine. So I think part of that may just be what the body goes through over a stint or a bout of using methamphetamine and up for days and not eating, not drinking. And that didn't happen so much on cocaine. We were able to kind of come down for a minute and be human and then go back up again. That was kind of my experience. So
Yeah.
I understand that, Rachel, that kind of differentiate between what a cocaine user does on a daily basis versus what a meth user does on a daily basis. Absolutely.
Thank you, Tanya, again for sharing your experience as well. Appreciate you being here and totally agree. You know, in the case that I presented, he sort of shocked me by saying he had basically been awake for about 5 to 6 weeks and had gotten to a point where like he was losing time. Like he would wake up places because his body he was so tremendously sleep deprived. I mean, he woke up once at a gas station, didn't remember driving, didn't know how he'd gotten there, and then went and used some more and then woke up someplace else. I mean, his experience of it was certainly of his substance use was a little different from what you hear from an experiential standpoint when people are talking about their cocaine use. Okay, I
Dr.
think that's
Shorter,
my time.
one last comment
Okay.
based on what Rachel and Tanya said is excellent. I mean, there is as we all know, there's also a biochemical difference between how meth and cocaine work and what Tanya and Rachel do. I mean, meth has multiple mechanisms how it works as compared to cocaine. So the neurotoxicity with methamphetamine is a lot more pronounced as compared to the neurotoxicity with cocaine. And the other thing is difference in half-life. Methamphetamine half-life is 16 to 14 hours. Cocaine half-life is 30 minutes to an hour and a half. So those are really some inherent biological differences which manifest different clinically. Yeah.
Absolutely.
Well,
Okay.
thank you so much,
Thank you.
Dr. Shorter. This was a wonderful discussion. I'm sure people have more questions, so please keep the questions coming in the chat. We'll keep the discussion going, but in the interest of time, we do have to move on to the next part of our session. Thank you again. With that, Taylor, could you please bring up the announcements from BWell? Thank you so much. To claim CME credits, you must text attend 10095777 to 844-502-1338 by midnight tonight. Next slide, please. I will request one of our team members from BWell, Laura Hall, to please give a brief introduction about this study.
Hello, my name is Laura. I'm one of the research assistants here at BWell. I just wanted to make everyone aware of a clinical trial we're currently recruiting for. It's meant for Texas residents who are diagnosed with opioid use disorder and who have recently begun Suboxone or buprenorphine treatment. The study is centered around the use of a mobile app, and it will be 13 weeks, fully virtual, and compensation will be provided. And I will send everyone the information after the session. If you have any questions, please reach out to our team, and thank you very much.
Thank you, Laura. Next slide, please. Please join UT Health San Antonio School of Dentistry for a statewide dental opioid summit on May 31st from 8 a.m. to 12 p.m. You can register for the summit, and we will be providing a link in the chat. Next slide, please. Join us on Thursday, May 30th for an exciting panel conversation with 3 experts across Texas, leveraging innovative models for the delivery of medications for opioid use disorder in underserved rural areas. To register, visit texas.org/sessions. Next slide. Join CSTAT for our session titled Communicating During a Public Health Emergency, Strategies for Effective Culturally Responsive Interventions. This will be on Tuesday, June 18th at 12 noon, and we will drop the link in the chat as well. Next slide. Please join us for our next session next ECHO session. This will be on Tuesday, June 18th, and Dr. Waklu will be speaking at this session. And with that, we will move on to our case. Taylor, if you could please share the case presentation, and Dr. Mum, you can take it away whenever you're ready.
Okay. All right. We'll make it quick. So I'm Dr. Mum. I'm the medical director for Olive Branch Recovery. We do a lot of mobile and telemedicine services for opioid use disorder, methamphetamine use disorder, and alcohol use disorder. So yeah, I've got a case here. Next slide, please. This is DA. He's a patient, 41 years old, no significant past medical history. He presents for a chief complaint of, I want to get off of pain pills. Little bit of history. His drug use started at the age of 16, initially started with marijuana as well as alcohol at the same time, then began using opioids about 1 to 2 years later. And he reports currently using marijuana 1 to 2 times per month, mostly to help him sleep, and reports drinking alcohol 4 to 5 times per week, about 6 to 8 ounces of bourbon at night. His use of oxycodone is somewhere between 100 to 180 milligrams per day. Pills, he gets them from a friend, and he says he has had long terms in his life, like when he doesn't use alcohol, doesn't use marijuana, but he just cannot go more than a day or two without using oxycodone. So next slide, please. So he's 41. He's never sought help for substance use before. He now wants help because of family and work stressors. He may lose his job if he is unwilling to get help. I think he had an ultimatum given to him by his family. His family owns like a shop, and so they found out about his usage of opioids, and they said pretty much get help or you're fired. So he reports that about 10 years ago that he and his wife had a daughter who died 7 days after birth. Also reports that one of his sons had to have open heart surgery soon after birth. He does identify these as significant life stressors, but he doesn't want to talk about them because they're just excuses, is what he says. Next slide. He lives at home with his wife and 2 sons, ages 6 and 8. He identifies his 2 sons as a reason for him to, in his words, get clean. He appears motivated and says his desire to quit is very high. Last use of oxycodone was the day that I saw him, and he reports to have easily stopped marijuana and alcohol, but not oxycodone. Next slide. No past medical history, no medications daily, no allergies. Next slide. Here's his DSM-5 criteria for opioid use disorder. His score is a 9, which puts him at severe. Next slide. Real quickly, his GAD-7 score of 6. And then next slide, his PHQ-9 was an 11. Next slide. Urine drug screen was positive for only oxycodone and THC, as he described. Next slide. And so I talked to him about, well, what are your goals for treatment? I think it's prudent to ask the patient, what do you want to do? Like, what is your next step? Kind of similar to what you said before. My goals might be different than your goals. So he says his goal is to just get off pain pills. He's not interested in decreasing his alcohol intake. He's not interested in any counseling services. Next slide. So always check the PDMP. It's funny because I found this slide that says no bad vibes today. Like, when you pull up a page, they got like a long list. It's like you got really bad vibes, I didn't get any bad vibes. There was literally nothing. He's used for decades, and there's literally nothing on his PDMP. Next slide. So I just open this up before the next slide to ask if there's any clarifying questions from anybody about this case yet so far.
Dr. Mum, it's hard to find prescription oxycodone on the streets these days. I mean, he's getting 100 to 180 milligrams. My God, that's a lot of oxycodone to find. I mean, people find oxycodone, they think they're getting Percocet, but as you all know, it's all fentanyl. So I'm not just surprised, I'm shocked that he's been able to find 180 milligrams of oxycodone for decades. I mean, it was easier earlier, but now it's not. So that's a surprising aspect of his presentation.
Yeah, when did that change? Do you know? Like, when did oxycodone kind of come off the streets?
The peak prescriptions were in 2012. Ever since The
Yeah.
clozapine is on the swing. And since 2015, my patients simply cannot find OxyContin and oxycodone on the streets. It's literally impossible.
That's interesting. So this patient, Dr. Waklu, I know this is, we do a lot of work in Texas, but this patient lives and works in Arkansas. So he, it may be a different case there. And so, but it was interesting because, on the urine drug screen, it was literally only THC and oxycodone, no, opiates was negative.
No fentanyl, right?
No fentanyl, that's right. Any other clarifying questions before we move on?
Is he still drinking heavily?
So that was what I mentioned, that what is it, 6 to 8 ounces? That was what he quantified. So he didn't say heavily, he said he would drink a few times a week, but he didn't say heavily. And so when we get to my question, that's part of what this is about, yes. Any other questions?
Did you do point of care fentanyl testing and it was negative?
Yes. Let's go to the next slide. No. So proposed diagnoses, opioid use disorder, severe. Treatment plan, next slide, is Suboxone 8-2 milligrams sublingual strips. Take 2 strips daily. We talked about mindfully decreasing alcohol consumption. We talked about seeking some counseling adjuncts as well. He did seem resistant to this. So next slide, please. So this is the question. Is his mom called me the next day or a couple days later, and she was very concerned. She said that he had been drinking, and she read online that he can, if he drinks alcohol with buprenorphine containing products, that you can die. And so my question is to the group is, what is the best approach for patients who also use alcohol concurrently with a MAT regimen? And I think this is I think we should also open it up to, what about other substances such as marijuana, benzodiazepines, and methamphetamines? For example, if you have a patient that has methamphetamine use disorder and opioid use disorder, but they say, well, I don't want to stop any methamphetamines, but I'm ready to stop the opioids. How do you handle this? How do you balance kind of the risk and benefit of treating one disorder with the other? And I'm sure that people will feel differently about marijuana versus benzodiazepines, but I just wanted to kind of open up that floor and ask people, how do we toe that line with different substances?
Dr. Mom, is he interested in cutting back on his alcohol use? I mean, was that one of his presenting issues?
He says no. He says he wasn't. When I saw him 2 weeks later, he did say that he was drinking 4 to 5 times per week before he started treatment, and now he's drinking about 3 times a week. And it kind of depends on if he's playing golf or not. So if he's playing golf all day, it's a lot of drinks in one day, but spread out throughout the entire day. But he is not interested in decreasing his alcohol use. But I find anecdotally that some patients do tend to drink less on this medication. It's not an FDA-approved medication for alcohol use disorder, but they do tend to drink less.
I'm just wondering, so his mother called you up.
Mm-hmm.
I'm wondering, is his alcohol an issue at home with his wife and kids? That there may be some, family issues that that are impacted, and and maybe it wasn't all his opiate use, but partly, and that won't necessarily go away completely if he's continuing to drink and he's on buprenorphine. Plus, you worry that over a period of time, that might escalate again.
Sure. Yeah.
Gonna focus on that in some way. It sounds like it would be important.
It's a little bit unusual because he came to me as a friend of a friend, and so his mom is the first one that reached out to me. Hey, like, we're having this crisis. Can you help? And so then when I saw the patient, he did not put her on consent. So, when I initially saw him, he said he didn't want to share any of that information with his mom, but then his mom called me a couple days later. Oh my gosh, he's drinking. And, I asked her, well, what do you think before he started buprenorphine treatment? What do you think he was taking with the alcohol then? I mean, oxycodone, right? So which one is worse?
You hate for something to happen when the mother had called you.
I know. And I told the mother and I told the patient, I tell every single one of my patients, you can die if you drink alcohol with this medication because it reduces your respiratory drive. If you take benzodiazepines, you can die, I mean, these are risks that we take, but I saw a statistic the other day that said approximately 30% of patients on medication-assisted treatment also use alcohol to some degree.
So this is Alicia, Dr. Kowalczyk. I was going to, just comment on two things. One, I'm sure you probably have, but I didn't hear it in your presentation. Educate him around OE&D and make sure he has naloxone and his family knows how to use it. That would be at least some type of stopgap if, of that concern. And I agree, probably a lot less risk with the buprenorphine than obviously with the oxycodone he was doing instead. I think sometimes it's a matter of time, and it sounds like he's attributed a lot of consequences that he's facing or lack of role fulfillment that he's faced over the past around his opiate use and not so much his alcohol use. But maybe with that knocked down and you stay engaged with him and keep him engaged in treatment, he'll start to realize all those consequences and that lack of role fulfillment is still continuing at a rate he's not happy with, and he becomes a little bit more internally motivated. I think, the other thing that, when I've worked with patients with other substance use along with their opiate use that doesn't immediately go away magically after we start buprenorphine, which we wouldn't expect, is again just using that period of time and also having folks come in for their visits or and I don't mean necessarily physically visits. Telly is okay too, but a little bit more frequent engagement and letting them know I don't feel fully comfortable going to monthly visits with this level of use because there is that risk. If you in his case, if he drinks a little too much, he may forget how much buprenorphine he took and take too much, or start mixing other things. So I think, there's that aspect as well, using that, if you can, for leverage to kind of increase his contact with treatment as much as he'll engage.
Yeah.
And yeah, I'll leave it there. Thanks.
Yeah, I agree. Tincture of time, and the more often you can see them, especially if they won't go to therapy and get some and work on things in a counseling kind of environment. It's going to be harder to engage them to look more, get a different kind of perspective, viewpoint on their life if it's monthly.
Yeah, I
Jump in
think I've
really
seen
quick
him.
before we run out of time. I had a client like that exactly as Like he was like, nope, I'm going to keep using, and this is what I'm going to do because it helps me. He was using methamphetamines, and I do it because I have that energy and I want to use each and every day, and it keeps me going. And if I don't use, then I can't get anything done. And I'm like, okay, I get it. I understand. I understand you're using it for energy, but okay, let's look at it in this perspective. Let's imagine your car. You fill your gas up. You fill up the gas tank with a lot of gas. You keep going, and you run out of gas. You keep filling it up with gas. What do you think is going to happen after a while? And he's like, well, don't you need an oil change? Don't you need to get a maintenance on it? That's your body. You need to go in to see the doctor. You need to get a physical. You can't keep using the meth and keep getting that gas in your body to keep going, keep going. You need to go see your doctor. You need to go get that physical. You need to get that checkup. And so he was like, oh, okay. So, maybe using that reality of, yeah, you can only go for a certain period of time, but you're the doctor, you know what's best for them, but eventually they'll figure it out, once the therapist, hopefully.
And I know we're at time, but I don't know if you've explored any, I know he's not receptive to counseling per se, so maybe not a kind of traditional counseling app, but maybe something that's more CM oriented. He's willing to engage. I know we do have one, available through the Be Well program for our participants for free, but those exist out there that he might resonate more with that modality of more a behavioral or therapeutic modality, but it's not a sit down across from someone or on a screen and share your problems, which he seems to want to not do.
He seems like the classic guy that wants to go out and play golf with his buddies and not connect with his feelings and not connect with his problems. There's obviously some trauma in his life that he needs to deal with. But my goal, my hope was that, hey, maybe if you let me treat you for a little while, you'll feel better and we can build some trust. And then maybe after a few weeks or a couple of months, then maybe you'll trust me to take the next step, And so I like that idea, Dr. King, tincture of time, give it some time and see how he feels. Because this is some guy that I bet he doesn't trust a lot of people, And so, yeah, I know we're running over, but I think it's an
guy exactly like this. It took him years to realize that alcohol is his worst enemy, but he still drinks. We're still working on it.
Yeah.
Well, thank you so much, Dr. Mum. This was a wonderful case, and thank you all for participating in this discussion. Dr. Waklu, if you could please help summarize the case for today.
So to summarize our current today's presentations, excellent presentation by Dr. Shorter on stimulant use disorders. Clearly, the likelihood of neurotoxicity with much more pronounced with methamphetamine as compared to cocaine, and we have about 5.4 million people in the country with cocaine use disorders, 2.7 million with meth use disorders, and there's a subset that co-uses both. He talked about differentiating between a substance-induced psychosis and a primary psychotic disorder, and the treatment management, pharmacological management primarily being olanzapine and quetiapine, with other treatments not being as superior, and also the synergy with cannabis use disorders. Dr. Mum's interesting, challenging presentation on a patient with multiple addictions, and the question is what to manage, and basically the goal being continued patient engagement and empathic caring and engagement, which basically that may not be a patient's goal now, but along the line, as you continue to engage with the patients and offer different treatment modalities, including some digitally based apps, which patient might be more likely to be keen to use. So I think that was the summary of both our presentations today, which is really very interesting and a lot of learning in this hour.
Thank you so much, Dr. Waklu, and thank you all for joining today's ECHO session. As a reminder, to earn CE credits, please text the activity code 1009-5777 to 844-502-1338 by midnight tonight. We also request you to complete the post-session feedback survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email cstat@ithska.edu. We look forward to seeing you at our next session on Tuesday, June 18th. Have a wonderful rest of your day. Thank you.